again, this goes into transitions of care, right? Which is you've been in the hospital setting, now you're in the outpatient setting, and this transition has to be smooth or it's all gonna just blow up and they're coming back in 30 days and somebody, at the very least, is gonna pay a lot of money. But it seems to me the money's the least of the issue. Somebody's gonna get sick. Are there new and novel approaches to transitions of care and coordination of care between the outpatient and the inpatient setting?
Well, I think there are a few, right? Each hospital has its own care transition strategy. We don't have a lot of data about which types of care transition strategy. People have talked about what goes in the syringe, right? We know that disease management works, but we don't know what the elements are that are important. But we think that every effective strategy contains some routinized discharge instructions for patients, some guidance about who and when to call for worsening symptoms, some guidance about how to recognize worsening symptoms, and some messages about adherence. The other pieces I think that are important are to recognize when disease is hitting that end stage, because the other thing we haven't even begun to touch on is what to do with the patient who can't tolerate the medicines or who's coming into the hospital despite all of our best efforts. And there, for a small few, there are salvage therapies, including cardiac transplantation and mechanical circulatory support, but that's the minority. And for the others, a lot of care transitions emphasize palliative care engagement and hospice engagement for the select few. And I think thinking a lot about where patients are in the trajectory of their illness and what supports they're going to need to stay well outside the hospital, to individualize disease management, that's a big part of our responsibility as physicians.
It seems to me that there has to be a mechanism, right? There has to be some sort of framework into which we can fit all these patients. Some accepted norm. Somebody's got to go out. You're going to be seen by a nurse. You're going to be seen by a physician extender. You're going to be seen by this physician. Here's your schedule. And here are the things we're going to be looking for. And to me, it's kind of amorphous right now. Does anybody have this framework in hand?
Well, I think we're all trying to build it. And each hospital, I think you could walk down the line and hear about different approaches that have been tried. But I think we're all trying to do exactly that, which is to create a framework into which we can drop patients as they leave the hospital so that they'll land softly and not end up back in the hospital.
Well, this has been a terrific discussion, not the least of which, reason for which is there's a new drug. There's a new class of drugs coming up, and the results are very good. So it implies that we need to get folks under control, under observation, into the system so they can gain the benefits from that. Is that a fair statement? That being said, it's time now to give each of you the last word, because we've come a long way, and I know you've had thoughts. So we're going to go around the table, ask each of you, and we're not going to interrupt you, not even I, to give a last word to our audience about what you think is important. And since you said, wow, Dr. Chow, it's yours.
We actually get the last word.
You
okay. Just overall, I think that it's very impressive that 2 new medications have been approved for the treatment of chronic heart failure over the last couple years. So it's amazing. You know, they have different outcomes, but both benefit patients with heart failure. So we have new strategies, new completely different mechanisms of action, first in class, very interesting, and you have guidelines that are supporting it. The problem is you can have all the guidelines and recommendations you want. If you don't start your patient on the medications, there isn't going to be an improvement in patient outcomes. So I think that's my thought.
Dr. Desai?
Well, I think this is an exciting time for heart failure management. We haven't had new drugs in a long time, and I think the availability of new drugs really reminds us that we have an obligation to apply the old drugs. And I think there is a need to recognize heart failure in all of its forms, to identify those patients with reduced ejection fraction where we have effective therapy, and to apply that therapy consistently to improve outcomes. This is a mortal disease, but it's one that can be modified over time.
Okay, Dr. Solomon.
Well, maybe I'll spend my minute talking about where's the unmet need still, because we've spent most of the time talking about heart failure, reduced ejection fraction, for which we are very fortunate. We have evidence-based therapies. But there are other disorders that we don't. And heart failure with preserved ejection fraction, HFpEF, is one where we're still looking. And so there are trials that are ongoing. We're hoping, in fact, with the ARNI, there's a large trial called Paragon that's testing this as well. We also know that there's potential in the post-MI setting, so there are trials there as well. In acute heart failure, unfortunately, we haven't had success. There have been a few notable failures in this area, and we still need a way to make patients feel better and also transition them when they come in with acute decompensated heart failure. So we've made a lot of progress in HFrEF. We haven't made progress in acute decompensated heart failure or HFpEF. That's where I think we need success.
And the last word goes to you, Dr. Vardeny.
That's some pressure. So I think I'm going to bring it around to the hospital. And we started off by saying that the hospital is the most burdensome, or hospitalization is the most burdensome outcome in terms of patients with heart failure. But one of the things that we can do to impact hospitalizations, or one of the most important things that we can do to impact hospitalizations or reduce them, is to optimize management in the outpatient. So that means we need to give patients the opportunity to be on good guideline-based doses of all of the drugs that we talked about. The new drugs and the old drugs, as Akshay was saying, should be evaluated, and patients should have the opportunity or deserve to be on the right doses of those as well.
Well, I'll tell you, from my perspective, listening to this discussion, it's exciting. There are a lot of diseases out there that when I was in medical school, which admittedly was a long time ago, we just wrote off. Nothing we can do. Take some dig, see you tomorrow, or see you in a month. Not true anymore. Really good stuff, really new medications with evidence-based effects that they work. That's exciting from my perspective. I'm delighted to be in a profession that can say things are moving forward. Things are going the right way. I want to thank all of you for being here and sharing that with us. I want to thank you for joining us as well. I'm Dr. Peter Salgo, and I'll see you next time.